These are depending upon the presence of risk factors and your age. So we will discuss it one by one. If you have diabetes and established cardiovascular disease, there is no question you should be started on a high intensity statin. Less than 40 years, you have diabetes. If you don't have any additional risk factors, no need for statins. If you have additional risk factors, you should be put on a moderately intensity statin or a high intensity statin depending upon the presence of the risk factors. 40 to 75 years similarly, for additional risk factors, you should be on moderate intensity statin. Additional risk factors, you should be on a high intensity statin. More than 75 years, people think that why should we give at this older age? But there also the recommendation is no additional risk factors. You should put on moderate intensity statin. With additional risk factors, you should use your own judgment to put the patient either on a moderate or a high intensity statin. What if the baseline is less than 2 millimolar or less than 80 milligram? The CARDS and HPS study has shown that still the patients benefit. So if the patient qualifies for statin therapy based on the algorithm, the statin should be given regardless of the baseline LDL cholesterol. So in summary, all diabetic patients except those less than 40 years without any additional risk factors should be started on statin therapy. So how do we monitor? The AAC recommends to check lipid values every 6 weeks. Every 6 weeks till the target levels are achieved. After that, you can do it every 6 to 12 months. We do it around 3 to 6 months to ensure that the compliance is there. Liver function, you have to test at baseline at 3 months after initiation of the treatment and every 6 months thereafter. But the US FDA recommends at baseline only. And if the ALT, the transaminases are going up to more than 3 times of normal, you should reduce or stop and follow up significantly. CPK creatinine level should be checked when patients report significant muscle weakness or myalgias. Not routine checking is recommended. Safety of statins, there is a concern regarding the safety of rosuvastatin in Asians, especially with the higher dosage. This is a recent study published in last month. 2,500 patients, there was no rhabdomyolysis. 1.8% only had myalgia in the short term, 6.4% in the long term. ALT elevation was only in the around 2% of the patients. So it is a relatively stable, safe form of therapy. What are the targets? AAC lipid targets for patients with type 2 diabetes. If you have if you are a high risk patient, the recommended level is less than 100 milligram. If you have atherosclerosis CVD or additional risk factors, the level should be achieved is less than 70 milligram. So 100 milligram and 70 milligram. Triglycerides less than 150 milligram. Non-HDL cholesterol you add 30 milligram to the LDL level. ACC-AHF actually they have no set specific targets for starting dosing as we have seen in the latest recommendations, but they also said that the LDL-C reduction more than 50% with high intensity statin from the baseline and 30 to 50% with a moderate intensity statin. So in a patient who is not having a good response with statin, it is recommended that you can add a non-statin medication. So statin intolerance is a common problem. 5 to 10% of the patients will develop some form of intolerance, mostly due to muscle symptoms. The ADA and ACC-AHA advocate a different type of statin, a lower dose of the same statin. Sometimes alternate dosing may help. Sometimes people have stopped and then re-challenged. The patient may tolerate that drug. If not able to tolerate the statin, switch to a non-statin medication. Whether the statins will further impair the glucose tolerance, that is another question. The meta-analysis of 9 RCTs of around 10,000 patients, mean follow-up of 3.6 years, it shows that there is a modest but significant increase in mean A1C level of 0.12%. So statins do worsen diabetes, glycemic status. So, but some data on the pitavastatin, we know that statins induce diabetes when it started on a patient without diabetes. There are a lot of discussions on that because of the lack of time and not going to the details. But pitavastatin has been found to be not having that much effect on the new onset diabetes. Meta-analysis of 15 short RCTs, 12 weeks duration study, total follow-up of 1,600 person years. There is no significant risk of diabetes compared to placebo. So what will you do if the triglycerides are more than 500? You have to start, or you have to prevent risk of pancreatitis by giving fibrates. and optimize glycemic control. Mostly the hypertriglyceridemia is due to many factors like alcohol, obesity, and dietary strategies. The second line agents, you should consider only if LDL-C target are not achieved with a statin or the patient is statin intolerant. The three agents are available: the cholesterol absorption inhibitors, fibrates, and nicotine. Relative risk reduction of 14%. So in patients who are not controlled on statin, you can add SMEB to get a better control of lipid levels. The field trial, which trialed fibrate in patients who diabetes, did not show any benefit. 10,000 patients followed for 5 years. The outcome was not very good. So the PCSK9 inhibitors, which are recently come, 25 randomized control trials, the meta-analysis of that shows that evolocumab or alirocumab LDL reduction very high, 36 to 59% reduction in LDL cholesterol, but you have to have a subcutaneous injection. This can be tried in patients who are intolerant to statins and very high risk of CVD and require those who require to reach LDL targets. Now we come to the last part of the talk about the HOPE-3 trial, which was I was asked to present. It's a double-blind placebo-controlled trial by a 2x2 factorial design where 12,000 patients were more than 55 and female more than 60 years who did not have cardiovascular disease were randomly assigned to receive cholesterol-lowering treatment with the rosuvastatin at 10 milligram and a 5.6 years follow-up. Landmark trial. The cholesterol-lowering arm was unique, that no entry criteria based on lipid levels, no routine monitoring, no dose titration, with low dose of rosuvastatin of 10 milligrams. So this was the primary endpoint. I am skipping that. You can see that a very significant improvement. P value is 0.0004. Cardiovascular death, MI, stroke, cardiac arrest, revascularization, heart failure. Very significant improvement with lipid lowering therapy. This also had a BP lowering arm. I am not going to that detail. That did not show that much benefit. So rosuvastatin 10 milligram per day reduced LDL cholesterol by 34.6, almost 1 millimole. Consistent regardless of LDL, SB, systolic BP risk factors, CRP level, ethnicity. So excess in some minor increase in side effects, no excess in rhabdomyolysis, myopathy or new diabetes. So statins benefit in intermediate risk patients without cardiovascular disease, 30% relative risk reduction with statins alone. This is a pragmatic strategy because there is no lipid or BP entry criteria or targets, no dose titration, infrequent safety monitoring. So strategy used in HOPE-3 is a simple, safe and effective, is a widely applicable primary prevention strategy. So newer anti-diabetic drugs, the liraglutide and limpagliflozin, very good cardiovascular outcomes. They are going to come as a second line drugs. So when the second line drugs come, how the statin is going to be in that place, we have to see in the coming years. So to conclude, take home messages: diabetic dyslipidemia, what is it? It is low HDL cholesterol, high triglyceride and low LDL, the high LDLP or the small dense LDL. Is statins the only choice? Statins is the first and the best choice. Do we need to treat all diabetic with statins? Yes. All patients less than 40, those without risk factors, all others need to be started on statins. What are the target levels? 100 milligram. If you have CVD or multiple risk factors, it is 70 milligrams. If LDL targets are not achieved, we can give ezetimibe as by the improved trial. Statins are relatively safe, but we have to monitor liver and muscle side effects. HOPE-3 brings more people under the umbrella of statins. Thank you.
Thank you, Dr. Harikrishnan. I think in view of the limited time, we can read one or two questions.
About pitavastatin, is the myalgia less? There are some claims that the myalgia is less. So it's pitavastatin. Is there such claim?
I don't have much experience with pitavastatin, but the study says that the overall muscle side effects are significantly less.
See, it's only used as a moderate intensity statin, not the high intensity. So I think the efficacy is less and side effects are also less.
Yeah.
I have two questions. Looking at the HOPE-3 trial in terms of primary prevention.
Yeah.
In moderate risk, it can be given. So any male above 40 and little bit obese, should we give to all of them? I mean, this is what.
That is what? That is a that is a controversial thing. If you have risk factors or you are an intermediate risk person, I think it is better to start on a low intensity statin. I don't think there is because it is found to be relatively safe. So it may not be a bad idea to start on a statin if you are having risk factors. At least 2 risk factors.
At what age? 40, yeah? What do you say?
Above 40. That is what.
Above 40.
That's already there.
Above 40 with.
No, if you are diabetes,
That's
yes.
already there.
Because age is a risk factor, male gender is a risk factor, weight gain is a risk factor, and we see all 3 very
The
commonly.
second question.
So I think most of the people sitting here will require a statin. In
Second question.
Yeah.
Your comments about saroglitazar, you did not mention. It
Yeah,
is Indian
saroglitazar.
molecule.
Yeah, the Indian molecule. Yeah, that's
It's mainly for triglyceride. Mainly for the triglyceride.
triglyceride benefit. Yeah, that's an Indian molecule. I think.
Somehow I think it's not very popular.
Sir,
for the cost maybe.
sir, newer second line drugs, how advantage over than others? Please explain.
Which anti-diabetic.
Well, anti-diabetic, 2 drugs you also.
Maybe the
newer.
last question.
Yeah, the liraglutide and empagliflozin. So they have the empagliflozin actually increases the LDL levels, but in one way in the serum, but it actually reduces the LDL-C absorption. So in that way it balances. So that is how. But empagliflozin has actually a very good cardiovascular outcomes otherwise, other than the independent of the lipid levels. That is what it is.
So many of our patients found to be vitamin D deficient, already presenting with myalgia. Any dose titration required in the statin therapy?
Vitamin E, I don't know there is any definite data to say that vitamin E supplementation improves the myalgia outcomes. But many people symptomatically get benefit by giving probably a placebo effect.
I think what they suggest is coenzyme Q.
Coenzyme, yeah.
Vitamin D was found to be useless in that, HOPE study. But I think coenzyme Q maybe. I think maybe one last question, if there is, otherwise we will wind up. So thank you, Dr. Harikrishnan. I think it was a very excellent presentation.
Thank you, sir.
And a good revision for me also and for all of us. Thank you so much.
Now I request Dr. Sadashivan sir to hand over the memento to Dr. Harikrishnan. And I also request Dr. Raghu to hand over the memento to Dr. Thomas Titus. Thank you. Now I invite Dr. Balachandran K, Senior Physician at Trivandrum, to chair the session on HbA1c, non-concordant with glucose reading interpretation and wisdom. The speaker of this session is Dr. Sanjeev Shah, Consultant Diabetologist at Mumbai.